after the last week, the biggest webinar maybe in the history of online for more than 13 hours, the International Trauma Webinar. I'd like to thank my dear friend, Dr. Srinivas, for his continuous effort for moderating the Indian session and the Indian experience in trauma. And of course, after 4 months from now, we'll have the International Hip Webinar, and we have a great session for our Indian colleagues, the Indian experience in hip surgery. First of all, I would like to say just one thing to my dear friend, Dr. Srinivas. Happy birthday, sir, and many happy returns. Thank you so much, sir. Now, we have a great day with two eminent speakers from India, Professor Bhavuk Garg, one of the eminent stars of spinal surgery in India, will speak about spinal osteotomies, and from Egypt, Professor Mohamed Fawzy Khatab, Professor of Orthopedic Surgery at Shams University, and the head of the AO Spine in Egypt, will speak about also spinal osteotomies from a different point of view. Many thanks to OrthoTV for live streaming these webinars to all Asian countries. First of all, we have our dear Indian professor, Professor Bhavuk Garg, and Professor Srinivas will be the moderator of this talk. Please, sir.
Good evening, everybody. As always, thank you, sir. I would like to thank Professor El-ashhab, Egyptian Orthopedic Association, IOATV, and OrthoTV. And thank you very much for your birthday wishes. Today we have Dr. Bhavuk Garg. He is a well-known spinal surgeon from India. He's an academician. He has published about 312 papers, 46 book chapters, 2 books, 222 paper posters, 282 guest lectures, and 6 patents. He works at, he's a professor of Department of Orthopedics at AIIMS, New Delhi. He has about 55 academic awards on his name. Main interests include complex spinal deformities, degenerative spine, infections, robotics, and MIS, artificial intelligence, apps, and biodesign. And his contributions include pioneering 3D printing in spine surgery in India and first 3D printing Ortho lab, enhanced recovery pathways in spine surgery, and 3D gait analysis lab in orthopedics, ortho genetic lab, and several surgical techniques. And the prestigious positions held include member of SRS Patient Education Committee, chair of SICOT Spine Committee, Young Fellows Association, liaison representative to the American College of Surgeons, chair of ASSI COVID Task Force, and associate editor for IJO, JCOT, and NASS journals. He studied mainly from New Delhi, India, and he also has MRCS from Glasgow. Fellowships include joint replacement and spine traveling fellowship, and fellowship from Germany, Dartmouth Spine Fellowship, SRS Global Outreach Spine Fellow, and IASA Fellow. He has multiple research grants as well. He has nicely summarized all these achievements in one slide. We'll be joining by Dr. Naresh Babu as a moderator later. He is a spine surgeon from Guntur, Andhra Pradesh, and he's a director and chief spine surgeon at Mallika hospitals. He is the distinction of being the first NB accredited spine fellow, spine surgeon of Andhra Pradesh, and he trained in spine surgery at Ganga Hospital in Coimbatore. He has been awarded multiple national awards as well as multiple international awards in spine surgery. He is a member of multiple professional groups related to spine of Switzerland, USA, Korea, Indian, and AO Spine, and member of the NAS USA, OSAP, and he's an editorial board member of Indian Spine Journal. Thank you very much, Dr. Bhavuk Garg and Dr. Naresh Babu for accepting the invite. I would like to invite Dr. Garg to start his talk. Thank you very much.
Thank you, Dr. Srinivas. Again, happy birthday to you. And I thank the Egyptian Orthopedic Association for this opportunity. And I have been to Egypt several times for their annual meeting in that great hotel, which is in the center of the Cairo. And I will be visiting Egypt in November this year again for the SICOT meeting, this thing. So I will start my talk on spinal osteotomies, that how we are pushing the boundaries with the help of these osteotomies. So these spinal osteotomies, they are actually a very powerful tool. And if employed properly, you can get drastic results with the help of these osteotomies. Properly, judicially executed, the outcome can be very great and satisfying for the patient as well as for the surgeon. And we use a lot of artificial intelligence tool for planning and the execution of these spinal deformities, these osteotomies. Like this is the SurgiMap software, which we commonly used for planning as well as the execution of these spinal osteotomies. These are the classical osteotomies described by the Schwab. He divided them into 6 categories. But I don't use this classification. I basically use this is a ladder which I use in my practice, that I start with look after the whether I can do the SPOs, Smith-Peterson osteotomies, or the Pontes osteotomies, or the posterior column osteotomies. Next, I see whether I can add the transforaminal correction if possible. Then I move to the pedicle subtraction osteotomy, then the extended pedicle subtraction osteotomies, closing opening wedge osteotomies, vertebral column resection. Then we have described our own modified VCR, which we call as the bridge over troubled water technique, and the combination of these osteotomies for various deformities. So we will cover them one by one. So the Smith-Peterson osteotomy or the Pontes osteotomy, they are just a little bit different, that in some matter that we just take out the inferior facet alone, and in some Pontes we take out the superior facet also. But basically they are all posterior column osteotomies, and we usually achieve around 10 to 15 degrees of correction in these cases. And this is how we usually do. We do the laminectomy, we take out the ligamentum flavum and the superior facets, and we create the chevron or the wedge-shaped area, and then we close it to get the correction. Now, when you are doing these sort of osteotomies, then you are basically opening up the anterior column, and one should be very well aware that we should see that there are no calcified vessels in front. And this osteotomy was described earlier for ankylosing spondylitis patients, and these patients, they have a very high incidence of these calcified vessels. So if you see these calcified vessels on the X-ray, don't do the Smith-Peterson osteotomies, because these patients, if you open up anteriorly, then they can get torrential bleeding from these, the tearing of these calcified vessels. Like this is an example of a Marfan syndrome, and you can see that he has got a severe kyphosis in the back. And this is his X-ray. I will just show you the simple steps that we normally expose subperiosteally. Then we use the screws at the strategic location. This is how we do these Smith-Peterson osteotomy. We take out the posterior, the column, and then with the help of the osteotome, we take out the inferior facet of the superior vertebra. And then this is how, when you cover this thing. So this is how it looks. You can see that this is a chevron shape of the defect which is there, and then you, with the help of the rods, you just close these osteotomies to get the final correction. And this is the correction which we have achieved in this patient. You can see that very nice sagittal correction here. This is the clinical post-op pictures. Again, a case of the Sherman kyphosis, and with the help of the multiple Smith-Peterson osteotomies, again you can get a very good correction in this sagittal profile. You can use these osteotomies for the scoliosis correction as well, for severe scoliosis. So you can get correction. This thing, you can see that how much mobility I can get with the help of these Pontes osteotomies. And this is like, you can see here that how much good correction we can get with the help of these Pontes osteotomies in these cases. Some of the cases which I have done with the Pontes osteotomies, severe cases, again, Pontes osteotomies, you can get good results. Now, this is an interesting case. This was a case of the growing rods and done somewhere else. And this patient developed the the crankshafting and the deformity at the adjacent levels going in the different directions. And this was the severe coronal as well as sagittal imbalance. When we opened it up, then there was a sheet of bone, because the autofusion is very common with these growth rods. So there was no way that I could correct this deformity in this fused area. So I had to use these posterior column osteotomies above and below, and then I could get a very good correction in the coronal and the sagittal plane just with the use of posterior column osteotomies. And you can see here the good coronal and the sagittal balance post-operatively. Now, coming to the second type of osteotomies, the SPOs with transforaminal correction. So this I commonly use for Angst patients who have got Anderson disease as well. So like this is a case with very severe positive sagittal imbalance. So rather than going long for these cases, we can just, with the help of a small fixation, posterior column osteotomies and the transforaminal putting a cage, we can get, leveraging it backside, you can get a very good correction. And like in this case, you can see here that a good sagittal balance we could get just with the small surgery rather than going for a long surgery. Now, coming to the third variety, the PSO, we take out the whole wedge from the pedicle, and this gives us a correction of around 30 degrees in the correction. So this is a case of congenital kyphosis, and you can see here that there is a very severe negative sagittal balance, which is commonly seen in these congenital cases. So these cases they are actually very difficult, because you have to correct from below upwards rather than going from above, from the above to the below side. In most of these cases. So this is how we perform with the help of the osteotomes. We take out the pedicles. This is the defect after taking out the pedicle subtraction. And this is how after closure, you can get a correction of around 30 degrees. So this is the post-operative picture. Now, this is again a case of post-traumatic this thing. Now, the dorsolumbar junction being straight, it is a very unique advantage because it is a straight thing. So you can use the osteotomy at the adjacent vertebra, not at the index level. So suppose there is a fracture of D12, you can do the osteotomy at L1 because that segment will make it a straight portion, which is a unique advantage of doing it at the dorsolumbar junction. Doing osteotomy at L1 is safer than doing it at D12. So like in this case, we have done the osteotomy at the L1 rather than the D12. And you can get a horizontal box, the rectangular box, which again gives you a straight dorsolumbar junction. And this is the clinical post-operative picture in the same patient. Now, these pedicle subtraction osteotomies, they are safer in the lumbar spine. However, when you move to the thoracic spine, they become relatively difficult because the cord manipulation can give rise to the certain paraplegia. So this patient has a post-tubercular spastic paraparesis, and we did the pedicle subtraction osteotomy here. And again, we could get good results and patient recovered completely with the help of these osteotomies. Now, you can use these sort of osteotomies, pedicle subtraction osteotomies, especially the asymmetrical, like means you take out a bigger wedge on the convex side and a smaller wedge on the concave side in the congenital scoliosis cases, and you can get a good correction like in this case. The post-operative clinical photographs. This is again a very severe, the congenital case, and I have done the PSO at the thoracic apex where there was a sharp, the curve. And you can see here that I use a small rod separately, which we call a satellite rod for these correction because it gives me a more controlled, the distraction at the osteotomy site. And once I have achieved the required, the distraction, then I use a bigger rod to span these osteotomies, and again I can get good correction with the help of these osteotomies. Coming to the fourth variety, the extended PSO. So if I require a bigger correction, then I go for a bigger wedge. The problem is that, when you close so much gap posteriorly, then the spinal cord can get kinking and the neuromonitoring signals, they can go. But if you are vigilant and you are monitoring and you have done enough releases, then in our experience, it is again a great method. So we just take out the pedicle subtraction osteotomy, and then I use burr to take out a bigger wedge, and then we close it. This is an example of a severe kyphosis at the dorsolumbar junction. 76 degrees post-tubercular kyphosis here. And sometimes we use different methods to close the osteotomies, sometimes manual closure. We have now the pro-access table, so we can use the table itself to close the osteotomy gap. And we can sometimes use the table to breaking the table and then closing the osteotomy for these cases. And this is how we, the intraoperatively, we have done the PSO, and I'm using the burr. So these are the pictures intraoperatively. You can see that I've taken out a wedge with the help of the osteotomes, and then I'm using burr to take out a bigger wedge. And this is the final closure intraoperatively. And you can see the correction here from 76 to 25 degree, which is again giving a correction of around 51 degrees for this thing. And these are the post-operative clinical pictures with a very good correction. Now, coming to the extended PSO, very severe cases. This is 115 degrees of kyphosis and very rigid postocular kyphosis in a 22-year-old girl. She developed tuberculosis at the age of, the 12 years. And for last, 10 years, she was like that only. And you can see that there's a healed sinus as well. And her chest has grown in the anterior-posterior direction because of this chest restriction. Very severe rigid deformity. And if you see the MRI, you can see that from D7 to L3 is actually fused in a single mass. So when I was doing the osteotomy here at the D7 pedicle, I was getting the signals at my vastus lateralis also. So again, these cases, they become quite complex. And this is like, how the extended pedicle osteotomy, when you have done, it looks like this. And with very careful and judicious closure, you can get good results, like from 115 degrees to 54 degrees kyphosis. And this is the post-operative correction. You can see here that this child has got good, the recovery. Congenital kyphosis, again, where they come in various sizes and shapes. And again, this sort of, the pedicle subtraction followed by the extended pedicle gives you a very good correction in these cases. And you can get a good coronal and the sagittal balance. Sometimes these congenital cases, they are not only in the sagittal plane, they are also in the coronal plane also. Like in this case, you can see here that the whole spine is shifted here. So again, here you can, some sort of asymmetrical extended PSO you can use here, and you can get good results. So I have done work on 3D printed jigs also, and we can use for these sort of, if you don't have navigation, then you can use these complex, the jigs formation, especially in congenital cases, and you can get the good correction like this in this child. Now, coming to the fifth type of variety, which is the most severe variety, we call as a vertebral column dissection. And usually we get this 60 to 70 degree of correction per VCR. And in this case, basically we separate the upper and the lower spine. And the only thing between these two segments is the nerves and the spinal cord. And again, then you can, you can correct the spine in the corrected position. So like classically, we do these cases now with the help of these posterior only VCR, but there are certain cases where you require both front and the back VCR. It is not possible to do posterior alone VCR. So like this is a case of 18-year-old male with progressive deformity. And if you see here that there is a dystrophic changes going on in the lumbar spine. So this is a case of neurofibromatosis. And if you see the CT scan, you can see that the whole of the vertebra is like extruded from is lying along the other side. So there is no way that in the lumbar spine, especially, that you can approach this spine from the back itself. So obviously, these cases, they require both the front and the back approach. And this is the clinical pictures of the same patient preoperatively. And there is a dural ectasia, which is fairly common in these cases. So we first did the patient in the lateral position, and we opened it up laterally. And you can see here that I have to ligate the iliolumbar vein, which was lying at the L4 level. And then I would take out that vertebra from the L4. And then we flipped the patient over, and then we did a posterior vertebral column dissection complete, and we could get good correction. So in this case, to achieve the coronal balance, I have used this. You can see here that I've used a vertical screw here, which we call as the kickstand screw, to shift the whole of the spine to the other side, and we could get good coronal and the sagittal balance. And these are the post-operative clinical pictures of the same patient. Now, coming to the cervical spine area, cervical spine VCR, they again require both front and back approach because of the presence of the vertebral artery. Like this is a case of postocular kyphosis, and here C5 to C7, they are fused in a single mass. So you can see here that in AP, you are actually looking at the spinal canal from the back. And this was how the child was fixed in a fixed direction, and there was a healed sinus also on the right side. And this was from the back. So I opened it up from the front first. I used a burr, and I burred everything from the in front, and I kept on moving laterally till I get the bleeding from the vessels around the vertebral artery, vena comitatus. So just the thin rim of foramen transverse area was left on the both side. And then I put a small cage, a mesh cage, to give it stability in the front. And then I flipped the patient back. and I put my screws. I tried to put the particular screws, but I could put only on the left side. On the right side, everything was fused. There was no landmarks because I used to put them freehand, and we have published a technique as well. So I could put lateral mass on one side and the pedicular screws on the other side, cervical pedicular screws, and we completed again the osteotomies laterally till the foramen transverse area, and then we used the cantilever mechanism to correct the deformity and breaking the foramen transverse area bone. And because we cantilevered it, so the anterior cage, it opened up because there was so much deformity correction. And then we have to go again in the front and we put a bigger cage, and then we molded the plate at the anterior cervical plate, and we put it here. And this is how we could get good correction in this child. And you can get the post-operative clinical picture. She developed C5 palsy, but she recovered within 3 months, and she had good the sagittal balance and the vision as well. This is another case in which I have used the C2 laminar screws and the all pedicular screws construct freehand. And this is the CT scan. They were all put freehand, cervical pedicular screws. You can see here. And this is the technique we have published also. Now, 3-year-old boy, like in this case, you can see again a very severe congenital kyphosis, multiple deformities. These sort of cases, they require the various meticulous planning, because vertebral column resection traditionally causes 2.5 liters of blood loss on an average, while the blood volume of a 3-year-old boy is hardly 1.2 liters. So one has to be very careful, very quick, and you have to use several maneuvers. So in these cases, the ultrasonic scalpel actually comes very handy, and it helps us to reduce the blood loss very much. And you need good anesthetic planning. The instruments, again, the implants, they are of problem. In this case, I have to use the cervical system because we didn't have the pediatric system that time. So the maximum size available was the 26 mm screws, and I could barely pass the pedicle, but they were enough good purchase, and I could get the good correction. And you can see here the post-operative correction in the patient. This is again a post-traumatic, kyphosis, and again I cut the anterior bone, and I used a bone, the T-leaf cage, the sizer, and I just used it as a lever, and then I could put a cage here and close the osteotomy in the functional results. Coming to doing VCR at the lumbosacral junction, it becomes a challenge because the anatomy is quite difficult, and there are a lot of ligaments and the ilolumbar vessels in front, so you have to be very careful. But if done properly and with the use of the S2AI screws, you can get good results. The sagittal correction is paramount importance in this case. Again, another VCR at the dorsalumbar junction. This is a double hump deformity, post-tubercular. Again, I had to use the VCR for this case. Another case for VCR. Now, this was a very severe congenital deformity at the lumbosacral junction, and you can see here that the iliac blade on the sacroiliac joint is dislocated on one side. So this required this special planning, and you can see here the CT scan. There was hardly any place to put the S1 screws in the distal one. So the only anchor which I had was the pelvis, and for correction this deformity, I had to use the 2 S2AI screws in the pelvis to get the optimal purchase distally, and this is how we can get a good coronal and the sagittal balance with the help of the VCR in this patient. The cervicothoracic VCRs, they become very challenging and very problematic because the artery of aorta is directly in front, and the vagal fibers, they are around the D4 area. So the anesthetist has to remain prepared for the atropine, because when you are dissecting around it, then there are often you can find asystole, and the atropine should be given immediately. This was a case multiply operated with severe deformity, and if you see here that his scapula was touching the mandible, and his ribs, they were touching the pelvis, so it was a very painful problem for this child. And again, you can see there were signal changes inside the cord. So this was a difficult case, and with proper planning and proper execution, we could get the good correction with the help of the VCR in the cervicothoracic junction. And this is the power of the correction was so much that actually the straight line tilted into the other side, the incision line, and this is the post-operative comparison of the bending film, the bending pictures. Now, coming to our technique, we have published this modified posterior vertebral column technique. So what we do, we maintain the most important step remains when you take out the posterior vertebral wall in the traditional VCR, because the cord is already draped over the posterior vertebral wall. When you take out this wall, then it causes the neurological deficit. So we keep the posterior column intact till the end. We complete the VCR here, and then we take out the posterior column. So this is how, like, these severe anaconda spines, very severe deformities. So we correct them with the help of this modified VCR, and this is the functional results. So he got married. He sent me a photograph from Nepal. Again, a very severe congenital kyphosis, neglected, this sagittal and the coronal deformity. And this again, I had used the modified VCR, and this is the clinical post-op pictures you can see here. Another severe case, the whole of the spine segment is lying horizontal, with the severe kyphosis here. And again, I had to use this modified VCR with an accessory rod here, and I could get a good correction. You can see here that this is the patient at the end of 6 months after surgery with a very good correction. Again, neurofibromatosis cases, very severe, because ribs, they are into the thorax, they become a challenge. And again, with the help of this modified VCR, we can get good combination. Now, the combination of these osteotomies, we have gone further. And when there is a global kyphosis, then we use these FBA technique, the full balance integrated. So we use these 3 parameters: C1 translational angle, pelvic tilt correctional angle, and the femoral obliquity angle. Like in this severe case, again, I had to use the multiple SPOs in this patient, and I could get the good results, the clinical results. This case, again, we calculated the angle, and we required the total resection angle of 70 degrees. So I did 1 PSO and 4 SPOs to get the angle of 70 degrees. And this, you can see here that I could get a good correction with the help of these this thing, and this is the correction. This was again a very severe case, AIIMS pond. So we have used these 3D models to look at to planning for the THR as well as the pelvic osteotomies, which is again a separate topic, how to balance the hip and spine in these sort of deformities. And then we use fenestrated cement augmented screws as well sometimes. And here I have to do 100 degrees of correction with the help of a VCR and the multiple Smith-Peterson osteotomies. Again, a very severe case. This was this thing, and 100 degrees of correction was required. So again, I have to use a VCR and a PSO in the same setting. I did this, and I could get a good correction. You can see here that the pre and the post-operative clinical pictures. Now, this was again a very severe case. The whole of the spine was like this. He was like this for 15 years. And again, here I've used the VCR, PSO, and the SPOs to get the correction from this bad to this straight. And this is the post-operative excellent. Now, this is the most severe case, and the last case, this which we have done. This was requiring 140 degrees of correction. So the only way was to do a 2-level VCR, which I did in the same sitting, and I did at L4 and L1. And this was the intraoperative pictures, and I could get a good correction. You can see here that from 140 degrees of correction with the help of 2-level VCR in the same patient. And this is the pre and the post-operative clinical pictures of the same patient. So these are complex procedures. They have to be done in neuromonitoring control. They have a high potential of neurological deficit if not done properly. Blood loss is a major concern, and you should use every measure to minimize it. Ultrasonic scalpel, hemostatic agents, tranexamic acid. Mean BP should always be more than 80 millimeter of mercury in these cases. And more or the less, this is more a teamwork, and your team should be fully aware and what you are going to do, and they should be aware of all the steps. Thank you.
Thank you so much, Professor Bhavuk Garg, for this very interesting case about these very complex cases. Thank you so much, sir.
Thank you.
Dr. Srinivas, you are the moderator of this session, please.
Thank you very much. Fantastic correction for some very challenging cases. I would like to invite Dr. Naresh Babu to take over the moderation. Thank you, sir.
Bhavuk, at the outset, I would like to thank KBS for giving the opportunity. It was a fantastic lecture by Bhavuk. I think you have seen the full spectrum of diseases being, osteotomies being covered, starting from pediatrics to adults with small different regions. So it's like interaction. Now, how do you do the moderation, KBS? You are like,
so you can ask questions. There are questions from the viewers also. If you look at the Q&A, there's one by Dr. Vijay Loya, and you can share your experiences as well with with the questions.
So the question for Bhavuk is, do you use navigation in such complex surgeries? I think he already explained. So what are the situations where you use navigation, where you do try freehand, and where you use your bone models, what you create?
So in my most of the cases, I use freehand. I am more comfortable with that, and I have been trained in that. But I have everything in my theater. So if I have doubt or if I have need, so I can always bring these cases in, my robot in or my OAM in. I always, will look at the 3D models, and sometimes for difficult cases, especially neurofibromatosis, these OAM navigation is certainly useful for putting your screws. But most of the time, these navigation, I've seen that they do not work in these severe cases because they are so fragile that they keep on moving actually. So the navigation doesn't work, and all these cases, your skills, they come into play. So to use them, the 3D models, they definitely play a role. So if you print a 3D model and you keep it on the table, then you can get a better idea in my practice, which I've found more useful for such severe cases.
So when you one more question, yeah. Once you have decided to operate on a particular kyphosis case, so how do you decide interop? Like, so you start with the simple PS1, then start expanding the invasiveness and go up, or you have pre-planned templates made and then you straight away go with the ideology of how you go.
So
any fix it? Yeah. Please.
So nowadays, actually, the volume is so much that now I can decide intraoperatively, just straight away going to the theater, that what I'm going to do. But if there's a sharp angular kyphosis, then I always start with PSO. If there is a diffuse sort of this thing, then I know that it is flexible, then I can get away with the posterior column osteotomies. But usually if I have to do a 3-column osteotomy, I start with PSO, and then I see that how much I'm getting it. If it is not PSO, then extended PSO. And sometimes just by doing breaking the anterior column, I can just get away with the closing opening with osteotomy as well. So, but if it requires more degrees of correction, like if I can make out that it requires more than 70 degrees of correction, then obviously I have to go for VCR. There is no point to that. Global kyphosis, we always do preoperative planning. Always do preoperative planning. Too much planning is involved in global kyphosis. So global kyphosis requires the femoral obliquity, the standing X-rays. You have to look at the C7 translation angle, as I told you, the pelvic tilt correction angle. Everything is taken into account. So they need to be managed preoperatively, everything.
May I ask, Bhavuk, excellent presentation. I enjoyed your talk and your difficult cases, but kindly can you highlight more regarding your technique for BVCR? You said that you preserve the posterior element and you do the corpectomy. So can you highlight and illustrate more regarding this technique?
So what happens in severe deformities? The cord is stretched over the vertebral body, right? So when you take out, so if you do the traditional vertebral column resection, so you take out the posterior column first, then the cord actually falls on the vertebral bodies further, because normally it is hanging with the help of the epidural veins to the posterior column. But once you take out the posterior column, then it falls back on the vertebral bodies. So now when you take out the posterior vertebral wall, which is the final step of the VCR, then you are inserting some sort of instrument between the cord and the posterior vertebral wall. Either you have to use the horseshoe, or you have to use the disc, the forceps. So the cord is already fallen upon on the vertebral wall, and you are putting a 2 mm or at least 3 mm instrument between the cord and this thing. So it further jeopardizes the cord blood supply, and it leads to the changes, the problems. But if the posterior column is intact, so we start lateral gutters, then we complete the VCR from the front, and then because the cord is hanging, so the cord is still healthy. There is still some space between the cord and the posterior vertebral wall. So after completing all the VCR, then we take out the posterior column, and then we put the correcting rod.
So you put working rod at the same time as well, or you don't use it?
So temporary rod is required at the very end, because the posterior column is still there.
Yeah, that makes sense. A very good technique. If you can look back, two advantages what I could see from the technique. One is it tries to prevent the translation, which usually happens. It happens when you do the osteotomy. The anterior column, proximal column tends to fall anterior, and then that zigzag thing, more than the kinking of the cord, the translation which causes the neurological deficit. So this keeping the posterior column intact will somehow try to prevent that one. And the second advantage is when you're doing it with a angular kyphosis, all your anterior column is seen up. So you don't need to really bend down and see, because entire vertebral body is above the spinous process or the proximal and distal things. It will be like that. So easy to do the anterior work first and then do it. So good technique. And also reduce the bleeding as well, I think.
Yes.
So we have some experience of doing the similar kind of works. But what we found out is if you're doing it in the children, most of the time you will get the correction what is more than we anticipate. Because the childhood spine, we think it's a little flexible and it also accommodates well. And the need for doing complete PVCRs will be a little less than compared to, you can get away with just extended or simple pedicle subtraction osteotomy. What do you think about pediatric deformity kyphosis corrections, especially when you are doing it?
So yes, I agree in pediatric kyphosis, especially if there is a small segmental kyphosis because of the failure of the segmentation. In those cases, if you just do the posterior column osteotomy, sometimes you can get away with just doing the posterior column osteotomy as well. Because what happens, the posterior columns, they elongate and the facets, they are separating. So they are actually, they are longer posteriorly. So by cutting the posterior column osteotomies, you can get actually 20 to 25 degrees of correction per level in these cases, because of the selective growth of the posterior this thing. So you can get good correction. And yes, I agree, they are flexible. So the margin of correction is too much as compared to an adult spine in pediatric age group.
Bhavuk, may I ask you regarding some of your cases that you present in extended BSO type of osteotomy, you didn't, although I feel that there is anterior column gap, you didn't use anterior cage in one or two cases that you present. Also, in some of cases with congenital failure of segmentation, you stopped at the apex of the dorsal kyphosis. You choose 3 level up, not more. Can you tell us more regarding this?
So I told you that if I'm doing a vertebral column resection, I have taken out the anterior, then I prefer to use a cage. But if I'm doing an extended PSO, then we do it under vision and we do it very gradual closure. So, and if we get signal problem in the neuromonitoring, this thing, then we add a cage, because I feel that bone to bone healing is much better in these cases. And that gives me much more correction also. So under neuromonitoring control, and if neuromonitoring control is okay, then I can just close it without a cage. Regarding the other question, that only 3 level up, 3 level down. So in angular kyphosis, you can get away with that thing. The problematic is the global kyphosis. So if there's a global kyphosis, then there are multiple compensatory mechanisms into play. So if these cases you get short, then you are definitely going to win problem. So you be very careful in selecting your patients, that where you can get. So in angular kyphosis cases, that normally, I go for sagittally stable vertebra in both the proximally as well as distally.
Okay.
Srinivas, you have a question, sir?
Yes, I just wanted to ask, in severe angles, how do you protect the great vessels anteriorly, and also the organ systems in the cavities, the thoracic and the abdominal, especially the retroperitoneal organs?
Yeah. So, it's all very basic techniques. So, you just cut the transverse process like in lumbar spine, or you take out the rib carefully, and then you have to stay on the vertebral body. And I use these ribbon gauges that I gradually dissect their front with the gradual spaces. And then once you have done the dissection, then we have special spoon retractors. You just put it there in the front and back, and then you are careful. In severe kyphosis, actually, the blood vessels and everything, they are in front. that is not a problem. The more problematic is the scoliosis cases, in which sometimes the vessels they also rotate. So one has to carefully study the anatomy on the MRI, that where the great vessels are, and one should be very careful. Sometimes in severe cases, I've seen that in fact, I have videos also that, the aorta is just lying below the transverse process, especially in Marfan syndromes. So when we were exposing actually, we could see the aorta pulsating at the level of the spinal processes itself. So if you put a nick between the two transverse processes, you're going to put the aorta. So one has to be very careful, and one should carefully see the MRI first, that where is the great vessels lying.
I think there is one question, sir, on Dr. Pasupati.
Yeah. The question is, screw pullout is a constant challenge during correction of a severe deformity. So yes, it is a problem if your screws they are not properly placed. And sometimes even if you place them, then again it becomes a challenge, especially if you are not gradual in your correction. So one has to be very gradual correction. And if you feel that the purchase of screws are not good, then increase the number of the screws in different directions. And sometimes I have to add, especially neurofibromatosis cases, I have to add the sublaminar wires, the hooks and everything, whatever you can do to get a good purchase in this thing. And sometimes we have found that if there's a negative sagittal imbalance, then putting your rods first into the distal screws and then bringing it on the proximal screws is much more useful, and the screw, the failure is less. While in positive sagittal imbalance, putting the rods first on the topmost screws and then bringing it down to the lowermost screws, they are useful. If you find that your screw purchase is not good, especially in the distal segments, then you can first put your screws and then you try to put both the rods together gradually. And I've seen that the cases which have got lordotic spine proximally, they have got the highest incidence of screw pull-out problems. So one has to be very careful, and they should increase the number of screws in those segments. Lordotic spine proximally is a bad prognostic sign for intraoperative difficulties.
Srinivas, we have any other questions, sir?
Any more questions, sir?
Okay, thank you so much. Finally, I would like to thank Dr. Bhavuk Garg and also Dr. Naresh for moderating this session, and Dr. Garg for his excellent presentation. Thank you so much, sir, for accepting our invitation. It's an honor for us, sir. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you, sir. Now we will move to the next speaker. Next speaker will be Professor Mohamed Fawzy Khatab, Professor of Orthopedic Surgery and Shams University and the head of the AO Spine chapter in Egypt. Professor Khatab will speak about spinal osteotomies, case presentation, different types and different indications. Please, sir.
Thank you so much, Professor El-ashhab, for the kind invitation, and I'd like to thank the Egyptian Orthopedic Association for endorsing this event. It is a great honor to be among these spine surgery stars from India, and Bhavuk was one of the invited speakers in our Scoliosis Week 2 years ago, and I am happy to meet him in the next November in Egypt, inshallah. My intending learning objectives from this talk to review the surgical treatment options for complex spine surgeries, why to operate upon patients with spine deformity, to outline Frank-Schwab classification for osteotomies, to put some tips and tricks for the tools of correction, how to prepare the patient preoperatively well, and to increase the safety of the patients. Spine deformity may occur in either axial, sagittal, or coronal plane deformity. It may be due to developmental causes like Sherman kyphosis, or idiopathic causes like adolescent idiopathic scoliosis, or iatrogenic like post-laminectomy, instability, or post-laminectomy kyphosis, or iatrogenic flat back syndrome. It may be also severe, especially in congenital cases like congenital malformation or congenital failure of segmentation. It can be severe deformity in syndromes like neurofibromatosis dystrophic type. It may also be complicated with revision surgeries, high-grade spondylolisthesis. It may be due to spinal tumors or inflammatory condition like ankylosing spondylitis or diffuse idiopathic hyperostosis. The spine deformity, if it is severe in the dorsal spine, it may cause pulmonary problems. Why we treat these patients? Because spine deformities or complex spine deformities may be a cause of pain. The pain due to either the local kyphosis or due to the compensatory mechanism from the spine to compensate and balance the spine. It is a significant cosmetic problem for patients, especially for teenagers, either males or females, and it may cause neurological impairment. And it is usually said that if you have local kyphosis more than 30 degrees at the thoracolumbar junction, you may have neurological deterioration by time. It may affect the development of other spine areas, and the development of chest wall and the body balance may be affected negatively. If it is a severe deformity over 80 degrees, can cause cardiopulmonary compromise. And of course, it affects the patient's quality of life. And psychological implications is really devastating for the patients and the families as well. Bridwell classified the spine deformity curves into total flexible curves, partially flexible curves, or rigid or totally inflexible curves. Why we need to know the rigidity and the flexibility of the spine deformity? Rigid deformity was previously thought that it is flexibility less than 25 degrees in bending the film, but with more knowing about the pathology and the biomechanics, we agreed then it is when flexibility is less than 50%. That means the curve could not be corrected more than 50%, either in fulcrum, bending views, or even some colleagues use traction under general anesthesia to assess the flexibility of the curve. It is also stated that it is a severe deformity and suspect rigidity when the magnitude exceeds 80 degrees. And by knowing that we are dealing with complex spine and rigid spine deformity, we need to properly plan our number of osteotomies previously, like as we heard from Bhavuk in the previous presentation. Where is the ideal location? What about the fixation points? And what about the fusion levels? Sagittal imbalance is a devastating complication, and it may be positive sagittal balance or negative sagittal balance. But when it is compensated and normal global sagittal alignment, it is type 1 sagittal imbalance, and type 2 where the spine cannot compensate for the local deformity and we have global sagittal imbalance. Frank Schwab classified the spine osteotomies into 6 types. It starts from partial facet, which is grade 1, and the grade 6, which is multiple vertebrae excision, and the adjacent discs are excised as well. As a spine surgeon, we need to prevent the progression of any deformity and restore the alignment and achieve maximum correction by fusing less levels and ending, of course, by balanced trunk. And we need to be quick surgeons, safe surgeons, use the simplest type of maneuver to help the patient, and it is important to less stressful to the patients and the implant. And I believe that multimodal neuromonitoring adds safety for the patient and safety for the surgeon as well, because we can control the correction power of our tools and of our osteotomies by supervising the patient's neurological state. Blood loss is a problem really during deformity correction. And the estimated blood loss and the autologous blood received for patients with adolescent idiopathic scoliosis, for example, increase when we use Ponte osteotomies. And it is stated in some literatures that all patients with osteotomies will receive blood transfusion, and it is likely related to the preoperative hemoglobin level and increase the number of osteotomies. So if we have patients and we are planning to operate, it is important to control the patient-related factor which can increase the bleeding. For example, if the patient has connective tissue disorders, Marfanoid features, for example, we can consider that he may have connective tissue disorders, so don't go anteriorly. Stay with the posterior approach and be fast and prepare enough blood for these patients because sometimes they may bleed a lot. Of course, proper optimization of the preoperative hemoglobin is mandatory because it is stated hemoglobin less than 11, increase the incidence of blood transfusion. And it is important to have more hemoglobin before doing the procedure, like, for example, 14, for example. Some colleagues may advocate or encourage to give auto donation prior to surgery or give iron injection, for example, to improve the hemoglobin and the iron of the patient. And of course, proper positioning of the patient is mandatory to avoid pressure over the abdomen. This decreases the bleeding from the engorged epidural veins. Normothermia and using the blanket to avoid hypothermia is important to decrease the bleeding. During the section, control the hypotension, mean arterial pressure around 65 millimeter mercury is important, and increase the mean arterial pressure to 90 or around the 90 while doing the correction maneuvers. By this mean you decrease the incidence of cord insult. Hemodilution strategy can be given by some anesthesia doctors, and of course nowadays tranexamic acid is a routine for all spine deformity surgeons, loading dose 10 milligram per kg prior to the incision and continue infusion 1 milligram per kg per hour until closure. And of course, a good surgeon is good and meticulous while dissecting, and some surgeons can use the cautery, bipolar cautery, ultrasonic scalpel, like we heard from Garg. And of course, if you have bleeding, you can use some Surgicel, Flocil, or Aresta, for example, and packing to control the bleeding. And if you have exposed bone surface that may bleed, you can use the bone wax, and of course, not too much and you can even remove it after a while before putting the graft to enhance the fusion. Cell saver is mandatory. Decortication usually done at the end of the procedure to increase the fusion bed, but decrease the bleeding surfaces and avoid drain if it is possible. Myself, don't apply drain in spine osteotomies or in scoliosis case. I use only posterior drain in cervical spine. If your surgery will exceed 5 hours or 6 hours, please be careful that you have 4 to 9-fold incidence of more bleeding and blood transfusion may be needed. If you have curve more than 70 or 80 degree, you may have 5 times fold to have blood transfusion. So proper team and 2 attending consultants to do such complex surgeries is highly recommended nowadays to be fast and safe to your patient. I will start to highlight some cases and highlight the different types of osteotomies, but I am following Schwab classification. Grade 1 osteotomy is partial facet joint resection. You remove the inferior facet and the joint capsule at a given spine level. It is a very common type of osteotomy. We do it in every fusion case, I can say, and used in spine fusions due to degenerative deformity. Any case we use to skeletonize the facet to enhance the fusion and increase the release and the flexibility of any deformity. Like this case, for example, it is a scoliosis link 5, female, 16 years old. She has thoracolumbar curve, 43 degree, and the facetal osteotomies and Schwab type 1 classification help me to correct the lumbar curve. Schwab is actually the kind of release that I used in this case. Like we can see here in this intraoperative photo, we release the facets, and this diagram can identify that we remove only the posterior facet in type 1. And of course, by the help of differential rod contouring, we increase in the lumbar spine, we increase the lordosis over the convex side, and we decrease the lordosis on the concave side to help the correction of the sagittal profile and help in derotation of the spine and correcting the coronal plane as well. So in this case, I rely on release by doing Schwab type 1 classification and differential rod contouring to reduce the sagittal profile of the patient, and of course some armamentarium like compression distraction. You may use rod translation, cantilever bending, in situ bending in such cases to help you to correct the deformity. For my dear participants, that it is usually I do compression over the convex side in the lumbar spine, because by this means I restore better lordosis, but I do distraction on the concave side in the dorsal spine, because this means I do some more kyphosis in the dorsal spine. Rod translation is a nice technique. Cantilever bending is useful. In situ bending by the coronal in situ bender, like the intraoperative photo that we put here, and we use to translate the apical vertebrae to the midline. For type 2 Schwab osteotomy, it is a complete facet joint excision. Both the superior and the inferior facets at a given spine segment are resected with complete ligamentum flavum removal. Other posterior element of the vertebrae like the lamina or spinous process may be resected as well. Like this diagram here, we remove the inferior facet, the superior facet, the spinous process, the ligamentum flavum, and it is a kind, we can call it ponte osteotomy, and it is usually provide 10 degree of correction at the level of open disc. And the hinge usually on the posterior aspect of the disc. And I use what is called the deformity T-left. I used to remove both facets on both sides. I used to put cage that far anterior in the intervertebral disc space with the bone graft, and then put the lordotic curve and compress over the spine segment. And by this mean, I use Frank Schwab type 2 osteotomy, complete facetectomies, putting the cage and hinge posteriorly, and by this mean I use to restore the lordosis. And this is my preferred method in doing degenerative cases to restore the lumbar lordosis. But also we can use ponte osteotomy and in a scoliosis correction. Like this example, it is a female patient, 26 years old, with adolescent idiopathic scoliosis, with linky 6 curve, thoracolumbar and main thoracic curves. The bigger is thoracolumbar curve, and I could correct her by multiple screw anchorage in a proper coronal and sagittal profiles. And we can see that the superimposed rods in the lateral view implies that we could achieve good derotation. Why we could achieve this? Not only because of the facetectomies and the ponte osteotomies, and not only but also due to the fixation, all pedicle screw constructs, and the periapical and the apical ponte osteotomies. By this mean we increase the flexibility of the curve, and we could correct the sagittal, coronal, and the axial profiles. And of course, there are some tips while doing these osteotomies in spine scoliosis deformity. You may need to increase the rod stiffness by using 6 millimeter rod or some other metal types like cobalt chrome. And of course, the differential rod contouring is mandatory to help you to do the derotation and correct the sagittal profile. And as I said before, I usually distract over the concave rod at the dorsal spine to help to create more kyphosis. Direct vertebral derotation can be done either segmental or regional after doing the release, the fascectomies and the Bonte osteotomies. And by this mean, we help to correct the axial plane rotation, which is manifested by the rib hump. And usually it is the primary concern for the patient. And of course, to correct this axial rotation, you need to have proper sagittal and coronal plane alignment before doing the derotation. And the direct vertebral derotation is very helpful because it may lead to better coronal curve correction, improve the lower instrumented vertebral tilt, and offer shorter fusion levels. So in this young generation, may I have more mobile segments that, of course, better for the patients. So in scoliosis, usually we rely on grade 1 and grade 2 osteotomies, fascectomies, and Ponte osteotomies. And of course, we need to correct the 3 axes. And we can say that compression, distraction, translation, cantilever is helpful besides the type of osteotomies. And of course, rod rotation, correct the sagittal profile, direct vertebral rotation, correct the axial plane deformity. We use Bonte osteotomy not only in scoliosis, or not only as well, or in degenerative cases, we use it in kyphosis correction. We can do complete fascectomies, periapical Ponte osteotomies, and we can correct kyphosis, like this patient with Sherman kyphosis, thoracolumbar type. We can correct by using multiple screws, or we currently use low density screw construct in correcting the Sherman kyphosis. Instead of using multiple screws and multiple anchorage points, we strategically anchor the spine proximally and distally. We use the upper construct, usually reach T2 or T3, and the lower instrumented vertebrae, usually the sagittally stable vertebrae. And we use only 6 screws up, 6 screws down, and we rely on correcting the deformity by multiple Ponte osteotomy. And we published this paper in the current orthopedic practice, and it covers the surgical management of Sherman kyphosis, efficacy and safety of low density constructs. And it may be very beneficial in countries with limited resources. Hypokyphosis also can be managed by this kind of osteotomy. Multiple Ponte osteotomy, and use a stiffer rod and long crown screw or screws connected with some towers can help you to restore the kyphosis. So we can say that type 2 Schwab osteotomy, we can use it in degenerative cases, in scoliosis cases, in Sherman kyphosis cases, and in cases of hypokyphosis. Like this female patient with hypokyphosis, she has back deformity of gradual onset progressive course. This is the clinical photo of the patient. We can see that she is really hyperlordotic in the dorsal spine with the right rib hump, and the right shoulder is up. And in any deformity case, in scoliosis case, we need to measure the main thoracic curve, the proximal thoracic curve, and the thoracolumbar lumbar curve, and to revisit the bending views to identify the structurality of the curve, because the structural curve usually will be fused. And we use this paper to plan our surgery. Where is the upper instrumented vertebrae after identification of the link classification, and what is the lower instrumented vertebrae, and what is the planned screw density. And for this patient, we did 5 Ponte osteotomy to correct the coronal and the sagittal thoracic hypokyphosis as well, from 8 degree to 18 degree. And we corrected the main thoracic curve from 41 to 14 degree with low screw density constructs. And in our cases, we used routinely, while closing the wound, vancomycin powder to increase the incidence of surgical site infection. Till now, we covered type 1 osteotomy and type 2 osteotomy and different indications. What about grade 3 osteotomy according to Schwab, which is the pedicle subtraction osteotomy? Partial wedge from the bone is resected with the pedicle, and we can achieve up to 25 degrees of correction. And here the hinge is the anterior body cortex. And of course, we shorten the posterior column, and it can be done at all levels of the spine, but preferable below the conus. This is a female patient, 52 years old, presented to me with back pain, and the patient has kyphotic spine, which is very stiff, and she thought that it may be due to her breasts. So she underwent breast reduction surgery to decrease the size and the weight of the breasts that caused her kyphotic problem, and it is complicated by infection. So the patient was psychologically upset and she divorced. So it was really a disaster for the patient. She visited me for the back pain, and I told her, you are a kyphotic because you have diffuse idiopathic hyperostosis, and your management not removing or reducing the size of the breast, your management by doing spine osteotomy. While I was examining her, I found there is exaggerated reflexes, and by examining properly the radiological investigations, I found that L4-5 and L5-S1 is really stenotics due to trial of calcification of the yellow ligament and some osteophytes here. So L4-5 and L5-S1 are very stenotic. It is proved as well here in the MRI. And I found that, as stated usually in the literature, she has ossification of the posterior longitudinal ligament behind C2-3, and this may be the cause of the exaggerated knee reflexes. So I decided to do laminectomy for her and lateral mass screw to widen the canal at this level before doing the correction osteotomies lower down. And I decided, because of the fusion mass in the facets, as we can see in the CT scan and the anterior fusion, not to attack the dorsal spine. I went for L2 and L4 pedicle subtraction osteotomies. I used the surgery map before doing for measurement and planning, and that is the pre and post-operative. The patient is balanced and she is happy, and this is 2.5 years post-operative. And for such severe cases, I rely on multiple rod system to decrease the incidence of implant failure. Not only pedicle subtraction osteotomy is stated for stiff spine due to inflammatory causes or congenital causes, but sometimes we face cases with atherogenic flat back. Like this female patient, 64 years old, presented with back pain, bilateral sciatica, medically free, only with history of DVT 1 year ago and recanalized. And she is on some medications to avoid DVT. It is important to stop these medications before doing the surgery. Also, the patient gave history of lumbar decompression 13 years ago. We can see the laminectomy is here, and the fusion 8 years ago, and the revision fusion 7 years ago. So I can pick that the patient has flat back, fused L3, 4 levels, and 5S1 is completely degeneration and the disc is gone. So I can say this is iatrogenic flat back and adjacent segment pathology due to the malalignment of the patient. We have vertical sacrum and spinopelvic mismatch. MRI can show you the signal intensity around the L5S1. So it is really painful and unstable. And I went to do what is called deformity T left at L5S1 level and the pedicle subtraction osteotomy at L4 to correct the spinopelvic mismatch. And of course, the lower instrumented levels will be the pelvis, S2 alar iliac screw, and the upper instrumented will be D12. It is a debate either to stop at D12 or L1 or D11 or D10. So I prefer to have the lowest stable vertebrae as the upper instrumented vertebrae. And I have some tips and tricks to avoid development of PGK. And this is the pre-op iatrogenic flat back, and this is the post-operative with restoration of the spinopelvic mismatch, and the patient is very happy and neurologically free. How to prevent adjacent level pathology, especially in managing these deformity cases? My tips is to careful soft tissue dissection. The interspinous ligament, the supraspinous ligament, even the facet capsule in the proximal part of the incision must be non-touched. Proper contouring of the rod is mandatory. No stress is applied for the rod to be laid down in the tulip of the screw. We need harmonious correction without any stresses. Of course, if the patient is osteoporotic, you may use some vertebroplasty in the adjacent level to decrease the incidence of fractures. You can, of course, enhance the patient bone quality by using teriparatides or anti-resorptive postoperatively and focusing on calcium and the vitamin D as well. The transition of loads by using hooks or some tapes or prophylactic anchoring in the reps, so what's called by soft landing to gradually transmit the loads is recommended. And in severe osteoporosis and in severe kyphotic global kyphosis, I'd like to go up to T2 to decrease the incidence of proximal junctional kyphosis and proximal junctional failure. And I recommend anyone of doing spine surgery is to optimize the spinopelvic parameter and strive to restore it. So till now, we can see that we can use many types of osteotomies for different indications, either managing degenerative, kyphosis, hypokyphosis, scoliosis, or even iatrogenic cases. What about grade 4 osteotomy? Grade 4 osteotomy is what is meant by extended BSO. You remove the pedicle part of the vertebral body and you include the end plate and the disc above. And of course, in the dorsal spine, you may remove 2 or 3 even rib heads to have wider space. In order, if you have anterior gap, you may need cage to be applied in extended time for osteotomy. I will present this female patient, 14 years old, with this failure of formation and segmentation at the lumbosacral junction. This patient was mismanaged by a spine surgeon, and he fixed her with the deformed spine, and the patient is still young, with potential to grow. And so the patient presented to me with progression of the deformity because of the mismanagement and with massive coronal malalignment. And so the decision was to do extended pedicle subtraction osteotomy, not attacking the hemivertebrae because of the great vessels and the lumbosacral trunk, and the devastating complication could be anticipated while dealing with this deformity. So my strategy here will do the osteotomy not at the center of rotation and the angulation, but I will do it to the nearest feasible point or the nearest point, and it will be extended pedicle subtraction osteotomy, unequal pedicle subtraction osteotomy, more on the convex side, less on the concave side, involving the disc to horizontalize the segment directly above the malformed spine. And this is the preoperative CT used for planning, and this is the intraoperative X-ray. In such difficult cases, we rely on Ibrahim Obaid technique. He published in European Spine. He used the domino. You put multiple anchorage up and multiple anchorage down and connect the rods through domino. No stresses over the screws. You use the domino and multiple anchorage points to correct the deformity. And also we use the kickstand rod to help the construct. And this is the lady before the procedure with coronal malalignment, and this is the lady after the procedure. So it is important to plan your osteotomy near the center of rotation and angulation. If not feasible, do it in the nearest point. 3-column osteotomy is indicated in a stiff deformity. In flexible deformity, you may use less weapons and more safe techniques for the patients. And extended BSO may provide up to 40 degrees of correction at one level. What about the BVCR, grade 5 osteotomy? You remove complete vertebrae, disc above and disc below. It is a circumferential resection with multiplanar circumferential correction. And I'd like to highlight for the participant this published paper in 2016 by Larry Lenke, speaking about the deformity angular ratio, which you measure the Cobb angle and divide it by the number of the vertebrae involved either in the coronal, in the sagittal plane, and before doing the posterior vertebral column resection, you calculate the risk. If the deformity angular ratio more than 25, so you may suspect up to 41 intraoperative neuromonitoring alerts. So it is mandatory to measure the deformity angular ratio before doing the BVCR. Like this patient, for example, 22 dorsal spine, 94 lumbar curve. If we measure the deformity angular ratio in the thoracic spine, it is 13. In the lumbar spine, it is 16. So the sum will be 29. So we have incidence 41% to have alerts with BVCR. That's why nowadays some colleagues start to do unequal pedicle subtraction osteotomies and preserving the concave side pedicle instead of doing the BVCR to decrease the incidence of neurological insults. myself use the BVCR in some congenital cases, like this boy with congenital kyphosis due to failure of segmentation at D9, 10, 11. We have here 3 fused spine segments with local kyphosis. I did BVCR and I reconstructed the anterior column by the mesh cage, and I used 3 level above and 3 level below. And it is mandatory, and it is a tip for any patients: don't step at apex of a deformity. Don't stop at apex of a deformity. Usually try to go away from the apex and fix your patients. Another case of congenital kyphoscoliosis due to failure of formation here. The patient presented to me with a spastic paraplegia. So it was the first presentation, it's a spastic paraplegia. Of course, he has the deformity since birth, but the parents bring the patient only when he developed the spastic paraplegia and urine and stool incontinence. And this is the CT and the MRI. There is a hemivertebrae here at the level of D10. In such cases, it is important to rule out VACTRAL, which is present in 20% of cases, which is vertebral, anal, cardiac, tracheoesophageal, renal abnormalities. And of course, the goal here is to decompress the neural structure, balance the spine, and prevent further progression. And that's what I did. I removed the hemivertebrae, and I don't need to reconstruct anteriorly. I have enough bone anteriorly, and I fix him. And the patient, for his good luck, he improved neurologically after the procedure. So it is important to manage your patient with kyphoscoliosis, especially in the thoracolumbar junction, either with failure of formation or failure of segmentation, because the neurological deterioration may be anticipated dramatically, causing significant comorbidities for the patient. So BVCR in congenital kyphosis, it can be done, and it is usually preferred for me instead of doing anterior and posterior procedure. But it is important to highlight in the consent of the patients that the neurological states may deteriorate or may not return, and that's why using the intraoperative neuromonitoring is mandatory in any deformity surgery. The last grade is type 6 osteotomy, and it enhances that multiple vertebral and disc could be removed. This is a male patient, 21 years old, with back pain and bilateral sciatica. His motor power is okay. No past medical history. In the MRI, we can see here hyper signal intensity in L1 and L2, and CT guided biopsy was done, and it reveals it is a chordoma. So chordoma in L1 and L2 in young age patients. That's why we agreed to do Schwab type 6 osteotomy. We removed 2 vertebral bodies and the adjoining disc. It was done front, back and the front procedure. Takes something like 8 hours with 1,500 blood loss. And this is the removal of the diseased vertebral bodies. And we reconstruct the anteriorly and posteriorly. Forward techniques was done to reconstruct posteriorly and anteriorly as well. We use the screws and pyramesh. This is the 6th type of osteotomies according to Schwab. But I consider that rib cage osteotomies is one of the spine osteotomies that we can do. Rib cage is the 4th dimension of the spine. And we can do rib osteotomies, either concave rib osteotomy to facilitate the patient's mobility on stiff curves. We can use subconvex rib osteotomies like thoracoplasty to decrease the rib hump after doing the correction. Even if you can see some rib hump, you can remove part of the rib. It can be done anteriorly or posteriorly, and even it can be done thoracoscopically. Like this 10 years old boy with scoliosis. This is the right rib hump. And we measured the cup angle of the patient, and we decided it is a link 3 and the candidate for D4 to L3 fixation. And this is the correction which we could achieve. But if you can see here, we removed up to 7 reps. This is the reps that we removed, because usually the patients came after the surgery asking about the rib hump. Even with proper correction, sometimes we can see the rib hump and we can remove it and take it as a graft for the bone fusion. And this is the final pre-op and final post-op coronal correction. So my take-home message that sagittal imbalance or coronal imbalance negatively affects the health-related quality of life. Tailor the osteotomy according to the pathology. We have 6 grades of spinal osteotomies. It is a tools. But proper patient selection, proper preoperative planning, kindly look for details, maintain the mean arterial pressure above 80 during deformity correction, avoid cord shortening by anterior column integrity reconstruction, strive for proper spinopelvic parameters restoration, and of course, enhancing the fusion and neuro monitoring is mandatory for such difficult cases. Thank you so much, and I am ready for any questions.
Thank you so much, Professor Mohamed Fawzy Khatab, head of the AO Spine chapter in Egypt and professor of orthopedic and spinal surgery at Shams University, for this very interesting and illustrative presentation. Thank you so much, sir.
Welcome, Professor El-ashhab.
I have a question for you, sir. What about the spinal osteotomies in ankylosing spondylitis?
Usually, ankylosing spondylitis can be managed, of course, if the chin-brow angle is non-favorable and the patient gaze is not horizontal. I used to do either L2 or L4 pedicle subtraction osteotomy, and usually it corrects the spine well. Sometimes, of course, if you have up deformity and the center of rotation and the angulation is up, I prefer to do D2 pedicle subtraction osteotomy instead of the previously stated C7 osteotomy, because correction at the D2 level is more safer for me. Affection of the brachial plexus and the lower trunk of the brachial plexus by doing the osteotomy at C7. I am not happy to have this complication, so I use it in one only case as I can remember, but most of the cases that I managed was by doing L4 or L4 and L2 pedicle subtraction osteotomy.
Yes, sir. And do you stage it osteotomy in such cases, sir?
No, I usually do it once, finishing the job in one posterior surgery, not staged.
Yes, sir. We have a question from Dr. Vijayawada, one of our dear attendees. What intraoperative measures you take to maintain shoulder balance in scoliosis surgery?
T1 tilt. In scoliosis surgery, I used to have X-ray by the image intensifier at the T1 tilt. This is the radiological measurement that I rely. Also, when you have proximal, for example, structural thoracic curve, I rely also with the restoration of the rib trajectory on right and left. So T1 tilt is mandatory, and the correction of the rib on right and left becomes symmetrical is also another sign.
Yes, sir. Thank you, sir. Dr. Garg, you have any comments, sir, or any questions?
No, I think everything is okay. Regarding the angst, it's a global kyphosis phenomena. So we have to plan very carefully. And I look at the pelvic incidence in these cases. And if the pelvic incidence is less than 70 degrees, then I do my osteotomy at L4. But if the pelvic incidence is more than 75 or 80 degrees, that means my apex goes up. So the apex of the lumbar lordosis is at L3. So in those cases, I prefer to do osteotomy at L3 rather than at L4, because I have to balance the spine, and the lumbar lordosis is almost equal to the pelvic incidence. So the higher the pelvic incidence, higher is the level of the lumbar osteotomy.
Yes, sir. I think we have no more questions, sir. Thank you so much. Finally, I would like to thank Professor Bhavuk Garg from India for his very interesting presentation. Dr. Mohamed Fawzy Khatab from AIIMS University from his excellent presentation. My dear friend, Dr. Srinivas, and also happy birthday, Dr. Srinivas. And also Dr. Naresh Babu for moderating the spine session of Dr. Garg. Many thanks to OrthoTV and to Eva Pharma Company for sponsoring this meeting. And see you in next Friday, inshallah, in lower limb trauma session with two speakers, one from India and one from Egypt. Thank you so much, and good night. Have a nice time. Thank you so much, sir.
Thank you very much.
Thank you very much.
Thank you.